had planned to have questions for the three speakers. Looking for questions for, yes.
About the food insecurity, are you doing any work with the schools in providing food to the school system?
The question is, with food insecurity, is any work going on with schools to provide improvements?
We have piloted giving Eat SF vouchers to school children at the beginning of school vacations. Food insecurity rates go way up during school vacations because kids don't have access to school breakfast and school lunch, so the parents are responsible for more meals. There are also many, many food pantries that are now co-located on school sites so that the schools have access to those food pantry offerings. And finally, there are many, many programs that are backpack programs where kids take food home on their back for the weekend. Those have had success, mostly because if you can imagine how much food your 6-year-old can take home on their backpack, it's not enough to make a meaningful difference. So we think that those really need to be augmented by other strategies.
Great. Question here.
I work a lot in the SROs in San Francisco, south of Market. And I see that beautiful produce get thrown away at the end of the day every time. Because the other half of the problem is that there's no place to store the food in the SROs or cook it. And I'm wondering, I'd love to work with you on going that extra mile into this complex problem in our SROs with regards to cooking and storage of food.
Yeah, there's lots
So
of...
the question is about SROs, which are single residence
Occupancy. Hotels.
in case anybody didn't know.
It is such a complex problem, and there's lots of work being done there, but one of the reasons I really, really like vouchers as a solution, not to say anything bad about food banks, they're a really great solution for some people too, is that people choose. They go to the grocery store and they decide what's right for them. If you don't have a kitchen and all you want is apples and bananas, get apples and bananas. If you have dentures and can never eat apples or corn, you never have to buy apples or corn. And we want people to be able to shop in the most dignified way possible and in the way that meets their own cultural needs and physical needs and kitchen access needs.
Good. Kirsten.
Yeah, I'd be curious to, one of the challenges when you work in complex systems like all three of you are working in is to figure out what outcomes you view as success, right? And especially we come from this biomedical model where success is, the outcome you have of your randomized controlled trial or your, the disease you cured, or how do you think about outcomes that tell you you're successful across your different interventions?
Laura, you're getting ready to speak.
I can. I will say that, that when we're talking about preterm birth, it's easy to talk about our outcome as being preterm birth or reducing gestational age or poor outcomes of prematurity. But for us, and there are other folks from the PTBI here, a big thing for me is bringing in more of the community voice, thinking about new ways of doing things differently, because we're not the first to look at the genetics of preterm birth, or the only ones. But how can we bring in the voices of the women with lived experience and maybe look at things differently, and maybe that's where we're actually see some change. So I think being flexible and also thinking about community voices has been sort of a big deal for us.
So we set out explicitly saying that we want to reduce the burden of cancer and cancer inequity. So one of the ways that we are going to measure, hopefully, because we can get cancer-specific data, is the change in incidence and mortality. But we also have a logic model for all of our task forces to look at intermediate stages of whatever the thing is that we're working on. So we also use that as a metric. I do a lot of community-based stories research, and I think one of the key principle that comes out of that is health outcome is not the only thing that matters. Even though I think for most of us, we are measured by health outcome, I actually think what's more matter is community capacity. Building that capacity is really important, because we don't even know if we saw one health outcome, we don't make something else worse. Whereas the community can then take whichever the problem is and keep on going. So building a model of working with organizations, with government, with communities to address whichever problem that comes up, that I think is really key.
Okay, Hillary.
I was hoping you'd skip me because that's such a hard problem in the work that I do.
It's Kirsten's question.
Measuring dietary intake and our health outcomes of interest, obesity, diabetes, is so hard. And food insecurity rates, too, is so hard. And I will tell you that we do the best we can, and we try to make all of our programming very rigorously evaluated, because we don't want to spend money on programs, particularly when we're implementing them at scale, that don't work. That being said, we sometimes do things that we take on faith because they are self-evident to me. So, for example, we do not need to prove again in our population that eating fruits and vegetables is associated with better health. And there are many people who would suggest we need to measure that in other studies, and I accept that, and I sometimes think that we get in the way of ourselves by demanding that we always have the health outcome or the dietary intake outcome, when really we could be measuring easier things.
Good. Rita?
I had a question that gets to Sandra's principle, I don't remember which it was, about the equity versus efficiency. So, a lot of what you guys were just saying is reducing, X disease, whatever it is. And I'm wondering how much in each of your different initiatives, what you look at instead is reducing the inequities, or specifically, I think in your work, it's sort of by definition you're working with vulnerable populations. But, for the others also, how, is that part of your initiative's ethos, or how do you justify that to funders that, we're maybe not going to improve the number overall, but we're going to, target it in this way, et cetera.
So I hope everybody heard the question, but basically, how do these different initiatives deal with the tension between reducing inequities and improving population health at the same time? Doug, do you want to take it?
Yeah, I think each of our task forces approach this differently. For example, the liver cancer task force is very explicit about disparities. It's explicit about disparities both in the Asian population, where a huge rates of liver cancers and viral hepatitis B, but also about the population that gets hepatitis C, which is obviously, as you know, many of them are also immigrants or substance users or various other risk factors. So we are very intentional about looking at disparities. The prostate cancer task force, as I mentioned, are intentional at looking at lowering the rate of prostate cancer morbidity and mortality among African American men. I think other task forces may take a different tact, but I think we do say that we are trying to drive down inequities, and by using a precision approach, I think we can at least look at what our work is doing in terms of, okay, we're not just driving the rates down across all parts of the city, we also want to make sure the rates in Bayview, Hunters Point, or the Mission, or Chinatown are going down as well, or even more than the rates going down in the city.
I will say that I used to roll my eyes when people would ask me to write out the paragraph about how my talk would address inequities, because I thought, it's about food insecurity. How could it not? But the truth of the matter is there are winners and losers even in the pantry population. There are people who have access to more resources. There are people who have more capacity time-wise or financially to access different systems that will help with their health. So even with this in the food pantry population, we have to be really careful to not exacerbate disparities there. And so from my perspective, it's really a matter of, even when we are explicitly looking at vulnerable populations, to find the vulnerable within the vulnerable and try to figure out how we can provide services that are more equitably resourced.
Stan?
So I have to be interdisciplinary and all that. Among smoking and tobacco use are concentrated among poor people. And they spend about a third of their disposable income on tobacco products. And so what can the kind of things you're doing and the channels that you've opened up, how can that crank in the work we're doing to try to reduce tobacco use among poor people in San Francisco?
Let me give you one simple factoid that might get your wheels spinning, because I know your wheels spin a lot, I can tell. When you ask many food insecure people, why did you buy the cigarette when you could have bought the salad? What they will say is, I mean, it takes a while to get here, but what people ultimately are able to articulate is that smoking blunts their appetite. And so smoking is actually, in many cases, a coping strategy to address the food insecurity. So when we try to reduce smoking rates in food insecure populations, damn, no wonder it's such an uphill battle, right? We have to think about all of these issues, as Dr. Galeo said, they are coexisting and they are intersecting, and it's really, really hard to address one without the other.
Well, so the question there, no, I knew that fact already, actually. If I started smoking, I would be so fat. But, I mean, we have been struggling with, like, what are the best channels to get to people? I mean, the belief people have about they smoke to deal with their hunger, in fact, if you got them to stop smoking and gave them the equivalent value in food, they would be better off. So, I mean, how...
Vouchers?
Huh?
Vouchers?
For what?
For healthy food, fruit and vegetable vouchers. Talk to me, we'll talk about Eat SF.
Okay, good.
And I will say for the preterm birth initiative, health equity is really the lens through which we do all of our work. And so, but I will say that's more easily said than done. And thanks, Bob, for the cough drop. When we're talking about black-white disparities, black women are twice as likely to deliver preterm. And that might say, okay, focus just on black women. But in California, we also know that more than 50% of all the births are to Hispanic Latino women. So when we're talking about US-born Latino women, where her risk of preterm birth is 20 to 40% higher, we also need to focus on Hispanic Latino women, given the vast burden of preterm birth. So trying to keep those two things in our sights at the same time can be quite challenging, but that's really what we're trying to do, and I think it's reflected in the SOLAR study, where we're really focusing on Black and Hispanic Latino women. But it's challenging, but it really is a guiding principle through which we do all of our work.
And you're measuring tobacco.
And we are measuring tobacco and food insecurity, so yes.
Good. Okay, yes, one more question here. You get two.
I hesitate.
No.
But, I've been working in public health for 34 years, and much of what we're talking about, we were talking about and working on in the 80s and 90s. I think we chase the problems, we chase the risks, we chase the details, and in a complex adaptive system, we really shouldn't be doing that. I like Principle 5, small changes in ubiquitous causes, but there's a flip side, I believe, and we don't get funded, is that we have ubiquitous strengths in our community that we need to pay attention to and strengthen, and then we don't need to follow these, I love that slide of the complex adaptive system. We don't need to chase those, because we'll never get to the end of those complex interactions. But if we strengthen communities, if we strengthen people's connectedness to community, I think we get the wealth of emerging systems, emerging ideas out of our communities. And I don't know, in the 35 years of working on this, how do we do that? Because when I talk to the funding folks at the endowment or wherever, they want to fund the problem. They want to fund a particular high-risk group or a high-risk issue and not basic community organizing, for example. I'm a little bit at a loss in that.
I think that's a great question. And it's a comment, but it's also the kind of question that we want to pose to the panel. So I'm going to use that comment as a way to break and take a break that can set up the panel that we have coming up. I'm pleased that Kevin Grumbach offered to lead this panel. He's one of our leaders at UCSF in matters of population importance. He's the chair of the Department of Family and Community Medicine, and he's also been a driving force in the San Francisco Health Improvement Partnership, SF-HIP, which has really consciously focused on how to improve community engagement and really make the kind of work that we do relevant to communities. So Kevin, lead the way.
Great, thanks, Bob. Good afternoon, everybody. You've met Kirsten and Sandro have been introduced, but Claire Brindis, let me then do the honor of introducing Claire. For those, most of you know her, Claire Brindis is the director of the Philip R. Lee Institute for Health Policy Studies here at UCSF. She's been part of the planning group for this and the whole effort around population health science at UCSF, has a background in public health science, popular health science, particularly focused on reproductive health issues, family planning issues, school-based health issues, and that doesn't even begin to scratch the surface of her manifold efforts in this area. So welcome. Maybe, but since everybody's been introduced, maybe we should introduce the audience a little bit, and I think it might help the panelists here just to get a bit of sense of who's here. So who here is a trainee right now, training in population health fields? All right. Who here is an educator who educates trainees? All right. Who here is does research, would call themselves a researcher in population health? Ah, okay. Who would consider themselves in the space of applied population health, really in the population health, public health interface? All right, so it's a diverse crowd, so we have a great range of folks. All right, so I think first we're going to have our three panelists just offer some reflections about what's been discussed today and a little bit about this moment in time for population health efforts here at UCSF, and then I'll prompt them with a few questions, and then we'd love to have some more interaction with all of you who are here today. So, yeah, maybe we'll start. Maybe we'll save Sandra for last. Don't you think that,
So I thought the day has been really inspiring to have our campus leadership here, to hear Sandro's sort of framing of this important field, and then to hear three areas that UCSF is working in. I have to say that as inspired as I am, I'm looking forward to this discussion because the answer of what an academic medical center should do in this area is still my question. And for many of these things, I wonder whether is the gap scholarship, and we need more scholarship in these areas? Is the gap that we need to be the translators and integrators of scholarship to actually move to action? What is our role in these areas? And that's what I would love us to talk about today.
So thanks very much, Kevin, and thank you all for coming today. And also thank you for a wonderful talk this afternoon. So I've been doing a lot of thinking about what I think we should be doing as an academic center, and also this time in our history as a country in which we are really fighting what the role of evidence is, the beliefs in alternative facts, the institutional racism that is really a really important issue that I think as an academic center we have to really consider how we're going to respond and how we incorporate that into our interventions. And so I've thought of actually about 8 different areas, and I'd just like to highlight those really, really briefly. So one task, I think, is the fact that we're all knowledge seekers, and also we are knowledge brokers and synthesizers, as well as knowledge curators. So I think that one big function of this type of activity across our center, or across our campus, is to be thinking about how do we bring evidence to bear on the life course kinds of problems that we heard in this last panel and in the topics that were discussed earlier. So I'd like to propose that we have a type of concierge service to bring together this kind of evidence and information. Another role is to be a spark of imagination, creating catalytic change. And that is that we have at UCSF a very courageous campus. I would look at Stan and the work that our campus did around tobacco, around HIV, around abortion, around sugar and obesity, around cancer, how we related to Stand Up for Science. We're not afraid of controversy. We also are unhappy about how things are in our lives and in our communities. So I think we need to think about what and how we can function as sparks. A third area, I think, is that we're major crystal ball map glazers. That is, surfers who are out there and the ocean is calm, but surfers often know when the next wave is coming. And I feel that many of you in this room know when the next wave of issues are that are going to be emerging. And for us to be really ready to respond, whether it's Zika virus or some other type of issue. But I think that we're living in a time where we really have to bring our intelligence to think about and be predictive, not just in terms of big data as predictive modeling, but also how we can use that information to be alchemists of transformation. A fourth area comes back to the area of translators and interpreters. My parents were court translators for over 20 years. And I can tell you that there's a very distinct difference between being a translator and an interpreter. And that partners, whether they be partners within the university or partners in the community, however you define community, are really looking for people who can do some of that synthesis and help to interpret what it means. But there's also the next step, which really has to do with accountability and humbleness. And that was a point that Tung raised about the fact that we don't have all the answers and we need to work with our partners, as Kevin has done for so many decades and a number of you have, but to be really thinking about how are we accountable to each other. If we think about food scarcity, we have to recognize that our own medical students and other students have been hungry, and we have had to create programs for our own individuals living and working and studying here. A fifth area has to do with value adding, a bridge builder. How do we bring the conversations that we had this afternoon to be thinking about how do we begin with pregnant women and how do we prevent obesity if they've had diabetes during their pregnancy, because that's going to lead to a lot of the problems that Tung has been thinking about, as well as many of other issues. So thinking about value added is an important element, including methodologies as value added. I'm very proud to be able to work with a number of health economists, and I think we need to be thinking about the economic factors in the same way that Hillary pointed out to the incredible expense of not taking care of basic problems like hunger. A sixth area has to do with leapfrogging, and that is that UCSF is a very wonderful environment in terms of our tone of collaboration. Why do we have to repeat errors if someone else on our campus has fought that battle? Can we learn from him or her and leapfrog into a new arena or new ways of using information that haven't been used before? And to be thinking about sharing of the data and sharing of the expertise and sharing of the databases and sharing of information. That commodity is extremely like a treasure, like a diamond. Seventh, I think, relates to being speakers of truth to justice. And our role as advocates is extremely important. Stand for Science is one example, but we have to be involved in advocacy in all aspects of our lives. And my final aspect of thinking about this population activity is to be thinking about legacy and how do we bring the next generation, both in terms of our students, our junior faculty, staff members, research assistants, everyone who's involved and who's working on some of these very intractable, complex problems. So I'll stop there for a moment, but I do want to share that Callie Milliner, who is a columnist for the San Francisco Chronicle, had a column recently on the Bureau of Linguistical Reality. Its mission is creating new language so we could better understand our lives in an uncertain university of climate change and other destabilizing events. It recognizes that our language needs to be able to name what we're experiencing. It was established in San Francisco in 2014 by two artists, Heidi Quante and Alicia Escott. And I want to give you two of the words that these women and their partners have come up with. First is shadow time. Shadow time is defined as being able to convey the sense of how it feels to live simultaneously in an uncertain present and a future with the potential to be dramatically different. So shadow time is where we are today. And finally, Karafi, the idea that some problems are too big for one person to hold alone.
All right, well, Sandra, let's, then using some of Claire's sort of laying out some ideas. I think Kirsten posed a pointed question, which is, why us, why now? Where are we positioned in this environment of an academic health center, a pure health sciences campus, without a school of public health? And then I think thinking of some of the things you laid out, Claire, for here are some of the opportunities. I think also challenging, you know, you're in San Francisco when one of the panelists talks about waiting, you know, surfing on the ocean, waiting for the waves, and new language development. So welcome to San Francisco, Sandro. But, you know, or is the answer just no, just give it up and you should go start a school of public health someplace else? Or do you think there's something that's unique, or there's a way we can position this in a place like UCSF that actually we should take advantage of?
Yeah, so first of all, before I address that question, let me address Claire. That was outstanding, those 8 points. I will need you to email them to me afterwards. I thought those were really, really interesting points about how we would intersect with something like population health science, and I just don't want to lose that in answering this question. Now, let me go back to the sort of fundamental question. You know, something's very interesting is happening around population health, and perhaps the simplest way, I have a slide on this, but just bear with me. So, you know, you can look at PubMed for population health. Now, PubMed for everything is going up. It's always going up. There's more of us publishing things. So what you have to do is you have to remove the secular trend. So if you did a PubMed search on population health divided by public health, just to get public health out of the way, what you find is sort of grumbling low level, not really changing much until about 2014, when then there's a hockey stick. It's actually like population health citations shoot up. Now, if you also looked at precision medicine, you find an exponential increase starting in sort of around the mid-aughts, and that dwarfs population health by tenfold. But something interesting is happening. Because
public health?
Public health is sort of slowly grumbling up. So population health has gotten traction despite the fact there's been no organized federal funding. There's been really nothing centrally organized. So I think it's actually very interesting. Now the question is, then I'll come to your question about, do we need a school of public health? I think it depends what you. This becomes a question of what do we mean by what we're saying. In my writing, what I've been saying is population health science, to my mind, is the fundamental science that informs the practice of public health. In much the same way as much biomedical research is the fundamental science that informs clinical medicine. So do you need a school of public health to do fundamental science work? And I would say the answer is no. I don't think you also need a medical school to do fundamental discovery science that can inform medicine. In some respects, frankly, not having a school of public health liberates you because you can actually shape the kind of science and the kind of inquiry that you do. So no, I don't think it is a school of public health. I actually think, I mean, there are pros and cons. Obviously, the cons of having a school of public health is that it ties you to certain requirements that you need to have and you need to approach because to meet accreditation and things like that from the School of Public Health. If you see population health science as the formative basic science that helps us understand how we generate health in populations, I think that opens up a whole wide vista, and I think then that the question becomes, how do you do that to rise to the 8 challenges that Claire posed?
So let me just put it on the table. So the one thing that distinguishes us from a School of Public Health is we have a large healthcare enterprise. And one of the things, the reasons why discussions about population health have gone up is because there have been incentives for healthcare organizations to align around population health management, which is loosely related to population health. Yes, exactly. How do we think about the fact that, apart from the scholarship and whether we need these disciplines to do the type of scholarship that would drive this, are there ways in which the fact that we are fundamentally a deliverer of health care, does that help us? Where are the opportunities for that to help us in the population health space? And is there the inevitable tension that we can't sort of act in this population health space? There's always a divide between what we do and what we write about.
Well, I'll answer and I'll turn it over to Claire. I think it helps in one simple way, which is data. I think it helps in data that you have an enormous healthcare delivery enterprise which generates enormous amount of data, which clever scientists can use to population health ends. I think it hurts you in the context of it bogs you down in confusion about population health management, which I think has very little to do with population health at all. But I do think that population health, and particularly quantitative population health, and I've written this, that needs to be much better at capitalizing on data availability. And I think healthcare systems do generate data which can be used. So I would shouldn't shamelessly use the data that's available to you without being co-opted to the healthcare enterprise.
I was going to say that I think Kevin, you and Amy have been doing a lot around using data and also incorporating social determinants of health within the data and really thinking about geographic, distribution of problems and thinking about how do you target interventions. And I'll use one example of Emily Finlayson, who is a colorectal cancer surgeon, Department of Surgery, the Institute, and she was very concerned about outcomes for the elderly, and that's one population that we all need to be concerned about. And most of the time, surgeons just care about the patient once they're in the hospital, and they are planning the discharge summary. What Emily has done is upstream, which I think is the reason I'm sharing this example, is because I think it has a lot of potential implications for others, and that is she sends nursing students and medical students as teams to people's homes before they come into the hospital so that they can really understand the home in which that person is living, their diet, their social supports, whether there's a rug that the patient is going to fall over, et cetera, et cetera. And using that data, showing that that person has a life before they come and then through the hospital operation experience and discharge can hopefully contribute to outcomes. And perhaps you should be commenting on some of the lessons that you've been learning in terms of population health management as a stepping stone to population health.
I'm just the moderator here, not the commentator. But you know, as we get going, I'll have lots of opinion. But I'm going to put down. But let's. And we'll get to the. But there's a little tension here. I think the applied and the basic science. Let's use that because it's the same thing with people in lab medicine. I'd hear would say is, don't always kind of push me or give me the framework that what I'm trying to discover is pure knowledge in the lab has to have some immediate translatable impact. It's generating knowledge that will advance the field and that will help, better science in lab medicine will ultimately lead to some breakthroughs that will have clinical application. So I think there's a little bit of tension because the panel, the three people who presented were very much in the applied space, right? Here's how we're taking some evidence, applying it into cancer prevention implementation, around food security, around how do we really engage with the community to try to make an impact on preterm birth. So there's a bit of a tension, and I think that tends to be a bit of our inclination because there's so much people with clinical backgrounds and wanting to sort of engage. How do we play out that tension where some of this is how do we just build the academic science and the rigor and the credibility in an academic health center, balancing it with the urge to do application and start to move into the implementation space? Is there a risk of jumping too far in the implementation? I say this as someone very much down that road, but that we need to tend to nurturing more of the basic science aspect of it.
Yeah, no, I think that's exactly a tension for me. And so, I hope my colleague Maria Glymer is going to comment too, because we have this conversation all the time. And so I think that, it might be easy to say that looking at the gene-environment interaction that is going to lead to, that helps me understand the mechanisms that underlie obesity, is that where our institution should focus its efforts, or do we just need to deal with the fact that something related to the food slide that Dr. Galea showed and the gene slide is probably where that interaction sits somewhere?
Yeah.
And
the gene pool hasn't changed that much in the last 30 years to go along with
and
it.
we need to, we probably know that there's some things we need to do in the environment, and that what Hillary's doing is exactly right on, and she doesn't have to prove fruits and vegetables are important. She's exactly right. She has to prove how we're going to get better food to more people, right? And I think that's exactly the tension, because we are obviously not just we are an academic medical center. Health center. Okay, health center. Yes, I focused on our health delivery part, but we are an academic part. So part of this is true for both schools of public health and academic health centers, is that we ultimately are, what is the academy's responsibility in thinking through, and how much do we still need fundamental research in these areas, not the tools of the basic scientists, but fundamental research, and how much do we sort of know, and we have to move to application.
Yeah, I will actually build on that. I think the fundamental question is, what does the academy do? What's the role of the academy? I think number one is to generate knowledge. Number two is to teach students. And number three is to make the knowledge accessible and to help translate it. I think those are the three fundamental responsibilities of an academic institution. So to go on number one for a second, in terms of generating knowledge, what knowledge does the academy generate? I think the great American university is founded on the principle that you hire great people and then you let them do what they want. So really the question becomes at the entry point. It's like, what kind of people are you hiring? So then the question becomes, well, you choose the kind of person you hire based on the vision for the institution. So it sounds to me like you're then wrestling, well, what's a vision for population health science and what scope does it make? Does it have? I mean, if you're interested in how genes interact with the environment, you're going to hire people who do that. Otherwise, you're not going to do that. And I think there are many equivalent visions. I really liked the new word about one person cannot hold it. And population health science, the scope is so vast that I think it's perfectly reasonable for UCSF or any institution to say, within this vast scope, we are going to focus on particular areas. And I think different choice of areas would be pretty equivalent. It just it depends a lot on the vision. I would argue, Kevin, to your point, that it's perfectly reasonable. There's room within a large, distinguished institution like this one to have a substantial focus on basic science with some focus also on implementation science. And those are obviously different creatures, right? You can't expect the same academic creature to do one and the other. Some do, but most don't, right? I think that's okay. I think you can have space for that. And that would make a very interesting palette. And again, if you're not bound by the requirements of an academic school of public health, you can be much freer in what you do around implementation science.
I think this conversation of underlying mechanisms is an opportunity for us to bring the basic, quote unquote, basic scientists. I consider population health a basic science, by the way. But I think in the past these are complex problems. It would have been easy we would have done it already. I think that's what you said earlier. So my thought about this is that we need to expand the conversation about what kind of research questions we ask when we're looking at genetics and when we're looking at environment and how they interact. And why is it that certain people within certain poor communities do really, really well and they're the positive deviants? And what can we learn from them as compared to others who are living in the same area that may have some aspect of genetic composition that we haven't figured out, but we need to understand the complexity in which they live. I want to share that my adopted grandfather was a materials engineer professor at UCLA, and I was a sociology undergrad, and so he and I would always have big debates about the fact that he had the hard sciences because he could have libraries and figure out how light would work, and I had the soft sciences because I just was trying to deal with human behavior. And I'd say, no, I think the reality is that I have the hard sciences because you can go to any library in any academic center and see rows and rows of books explaining much of materials engineering. But even with light, we thought we was particles or we thought it was waves. And finally we figured out that it was both. So I think part of science is building, and building on what we know and going into new areas.
So some people, I think part of this is really to understand also from you, what do you think it would take to get us to the next level to really advance this, to assert a much stronger population health science program here at UCSF? So I think that's partly the flavor. Yeah, Mark.
I just want to say you guys sort of just missed the sort of intersection between the population health efforts at the medical center and population science. But don't you think there's an opportunity there to gather the strength of the medical center and use that for population science?
Yeah, I actually don't.
Can people hear? Did people hear, or do you need the questions repeated?
Please repeat it.
Yeah, Mark Pletcher asked about. Did we actually give short shrift to the idea, are there ways we could capitalize on being in an academic health center with a giant clinical delivery system here at UCSF Health, our partnering organizations like San Francisco General and the county system, the VA? Actually, could we take more advantage of that for population health science work?
Yeah, I mean, thanks for bringing that up, because I do think it's easy to be cynical about this, in part because the same terms are being used to apply to sort of, like at its extreme, there's very little relationship between the two. I think what's interesting, though, is to look at the way institutions that have been thinking about population health management for a while have actually used those alignment of the financial incentives to think about health beyond their clinical walls, right? And so, and there's some creative examples. I think the Robert Wood Johnson just recently published a set of case studies on this. And I do think, because I think our institutions still, the financial incentives, when they align, allow us to do much more. And I think thinking about our institutions both as deliverers of health care and how can we use that model to further population health, I think, is one area. I think we are ourselves economic actors, right? And so one of the things that Kevin has talked a lot about is our institution as an anchor institution and thinking about our role in those things. So I do think that there are ways we should think about the standard things that motivate our institutions, right? And how those align to further what we do in population health. And I think one of these areas that is intriguing to me is this aligning incentives so that population health management may start to look like health centers going into the health of the populations in their region, and also, the interest in sort of the social determinants of health integrated into the clinical practice to start to think in those arenas. And I think both of those allow us the opportunity to think more along these lines.
I actually, if I can take a look, I think it's good you're kind of bringing this back to us. So there has been real effort to not let people get away with saying, oh yeah, I sit here doing managed care at a health system, that's population health. That's a bit of a, let's say, unreasonable adaptation of the term. Because what it really is managed clinical care. But that said, and this is where I challenge and push back a little bit, because having sat in that position, I was Vice President of Population Health for the UCSF health system for several years. The conversation changes because people are, if you look at your definition of population health, the one that the working group here did, it starts talking about thinking about distributions across a group of people rather than just individuals one by one. And that's true for population health management as well as real, we'd say, broader community level population health. And so it does start to get people to think differently. And I know it's Tung and others working on this space, because you're starting to think, whoa, it's not just one by one taking care of this patient sitting in front of me, and how do I optimize that individual's care, but I'm actually starting to be, even in the term accountable care organizations, accountable for this whole group of patients. And you have to start thinking much more explicitly about trade-offs. You start having to think more about upstream interventions, preventive, what you're talking about with the surgeon, thinking, actually, how would I intervene before I operate on an elderly person who may be frail, to understand what would it take to prevent that person having a complication, or even understanding, are they appropriate for surgery, and understanding the broader context of the life. So I will say it's shifting the consciousness, I think, in healthcare delivery organizations that starts to pick up at least some of the flavor of population health science in a more fundamental notion of population health science that I think is only good. And now what you do is you collide is, well, wait, we're not dealing with social determinants in the Office of Population Health, we're dealing with care management, but pretty soon you realize that person who's been hospitalized multiple times, you are going to actually have to take the leap, and I think this is what healthcare organizations, to do something with housing, because you can't solve it in the pure clinical care. So I'd say both we need to make sure we're not misusing the term for what's essentially clear clinical management operations, but I think it's opening up a whole new vista. And I think Dan Lowenstein's comments here is in part because people in the clinical space realize all this stuff makes much more of a difference than was recognized at first in a very individualistic, mechanistic approach to care. That's my sense.
Let me just comment. I actually think that the nuance Kevin brought to that is very, very, very important. The fact is that medical centers across the country have been doing some very innovative work around what I would call population health. I mean, the medical system that's affiliated with my university, which is a safety net hospital, Boston City, they recently invested $6 million in housing. And that's very much informed by a population health discussion within the hospital. So I tend to think that anything that shifts the conversation so that the medical care providers can find a role is important. I was reacting reacting to what you called the appropriation, the misappropriation of the. One, if it's helpful to you all, one story which I found resonates with physicians is the firefighters equivalent. Right? Firefighters used to only put out fires until about 50 years ago, until they realized that they could actually work to prevent fires. And in so doing, there are now more firefighters than there were 50 years ago, and there are data on this, I can see in the slides. And physicians are actually, they want to keep people healthy. I mean, that's why they went to medical school. Now, when you go to medical school, that gets beaten out of you, and at the end of the, by the time you're in your mid-40s, your goals are very different. But I do think the population health science has a chance to tap back into that well of goodwill.
Oh boy, all right, yeah.
So I agree with Kirsten that one of the main resources is the data that we have. My one hesitation with that is that the types of data that we have are for the types of patients who end up at like a tertiary care academic medical center in Northern California. So that I think is also one of our limitations or cautions in moving forward with our own data. The other thing I was going to say that, before I was sitting here, I wasn't thinking of it as a resource, but I think one of the biggest resources potentially is our patients, the human beings that we interact with every day that, at like a school of public health or, like an economics department, they don't have interactions with the actual human beings who they're studying. That in this case, we have that. We have that as a resource for potentially building partnerships, like the PTBI work where they're actually working with community partners to solve, presumably a clinical problem. And I was sort of thinking this is how I see my own career, maybe others do too, who are both clinicians and researchers, that we sort of keep our foot in the clinical world in order to have that connection with human beings so that we can, think better about our research and have those types of synergies.
Yeah, here's two. One is a commentary about clinician scientists may be able to connect that sense of touching patients with the broader population health. That's one point I think Rita you made. And the other was about as we start to think about electronic medical record data essentially as opening up vistas for population health science, because it's all the big data that's suddenly available. Do we need to be careful that it's not a rather skewed population consisting of those who get care in an academic health center? So. I want to take that on.
I would I totally agree with you. I mean, I think people who delve into using clinical data, even if you're using it for clinical algorithms, right, it has its own set of unique challenges that have to do with the population and the generalizability, and you're only observing when they're in care and all of those other things. But I think thinking about this, and I'm just going to point out Tomas here, who's our from the Department of Public Health, and you think about the Department of Public Health charged with, in the face of all of these epidemics that we're talking about, and how much data we collect, that they're in charge of sort of dealing with, that there's the lack of information to actually think about the health of the population across all the three of these things that you talked about, I think is one of the main things. That's why I know I'm so happy that the Department of Public Health has some seed funding from the Bloomberg Initiative to try to think about how we as health systems should be sharing data better.
Other questions up here, and I think I'll just rotate the mic up here. We'll get back. Hillary, well, let's get some new voice, and then we'll come back to Hillary. All right.
Close.
Other than Tomas, I think all health departments and all schools of public health should be disbanded and defunded, and the money distributed to the poor populations of their constituency. That's my null hypothesis.
All right, anybody want to take that on, or do we just, yeah?
How about medical centers? Just disband them all.
There's something to that.
All right, we'll let the group ponder that. Who?
I'm a student from the School of Nursing, and I wanted to speak to Sandro's point that one of the roles of an academic medical center is educating students. And I think that we have a responsibility to educate students who are reflective of the populations that we're caring for. And to speak to Claire's point that there is a food pantry on campus for students, is that we also need to be able to support those students when they get here. Because I think when we lose that, we lose a lot of the research that we could be doing and a lot of the answers that could be coming from within.
Absolutely.
Support our students.
Absolutely.
Yeah, I just think we need to, I think racism is a common thread that exists throughout Sandro's points and Hillary's, and I think we need to look at what we're doing also. participating in that.
Hillary, all right, I should walk right by you. Did I miss your?
No, I just was going to mention that a lot of, when I think about population health, maybe this is too simplistic, but I think about working very deeply and authentically at the space between healthcare and public health. And that's a really, really hard space to be in. But if we were to dismantle the system and recreate it from the ground up, we wouldn't have two systems. We would have one system. So that presents an opportunity in San Francisco, I think, because we've always worked really closely with the healthcare system, with the public health system. We're very deeply integrated with them. And if we could more intentionally create a system without the walls between our two systems, I think that we could contribute an enormous amount to the population health debate.
So if anything, maybe we're poised to do something incredibly special and overcome some of these barriers. Yeah. Come on, all right. Yeah, and please introduce yourself.
Tomas Aragon, Health Officer, San Francisco. So there are some challenges. So we're called the Department of Public Health, but we're really the Department of Healthcare Services that has a public health unit attached to it. Budgetary-wise, we're about 4% of the budget. Okay. One of the challenges is when you have an integrated system, is that the emphasis is on where there's fiscal risk, where there's financial risk, and so most of the effort is in dealing with that. So there's a huge emphasis on the healthcare services because that's where all the financial risk is, and there's very little money that actually goes into upstream primary prevention. And so, in fact, I actually think it absolutely has to be separated. The examples that we saw were at the state level when public health separated from the Department of Health Services, where they were able to advocate for money to work on climate change, be able to work on the built environment. LA County, when they separated out, and that's one of the reasons why they have not been put back together, is because you need to advocate to policymakers for investments in that. If your healthcare is always going to cost so much more, 20 times, 50 times more than public health, because we focus on upstream policy solutions that save everybody money forever into the future. But when it's attached to something that has huge financial risk, it doesn't get that investment. It has to be separate, it has to advocate. And so I think there's some risk in having one system. We have one system, it'll be like we have now. We're a unit that's attached. There are some benefits, but it's San Francisco's working out okay, but we've seen the experiment in other places that it's a problem.
Just to people, what Tomas is referring to, just so everybody's clear, the San Francisco Department of Public Health runs this huge clinical system, the San Francisco Health Network with San Francisco General, Laguna Honda, a bunch of clinics, and that's 95% plus of the budget for the health department, which may be Medi-Cal revenues and revenue generating things as well as general fund. But right. And you sit overseeing the true public health population side of it and find yourself a bit overshadowed by the whole clinical operation side.
It's common throughout the United States. It's not unique to San Francisco.
I would just like to stress the importance of our paradigm in terms of how we think of population. And I think so much of the approach of population is a consideration of individuals collectively added one to the other. And I think this paradigm of atomism and Cartesianism and whatever is based on the assumption of atomistic individual and society, as if they're two different things. And there's lots of important paradigms in phenomenology or whatever that consider more than the individual as your unit of analysis. Excuse me. And even now, I've been doing some work with Barbara Koenig on genetics and people's understanding of genetics. And what is very interesting is people are saying the genome, in terms of who gives their genetic sample, and whether that is shared with the family. And people are saying that genetic information does not just belong to that individual. It belongs to all of us, all of our relatives. So even there, the breakdown between the individual, the unconnected person, and the family doesn't necessarily hold. They don't necessarily think of their genome as something individual, but rather familial. And I think dealing with this individualism implicit in so much of our sciences and in the clinic is a fundamental step for a serious population health.
Just to add one more, maybe relatively narrow frame to thinking about why we need this, as if I take on my clinician and educator hat, I think the crisis in the health professions as providers of burnout, et cetera, has heavily to do, or some component of that has to do with our inability to effect change with our patients, whether that's me as an inpatient provider or otherwise, by not addressing population health issues. And I think integrating that into how we're trained as clinicians, or integrating ourselves across these systems within the institution might go a long way to really addressing some of this essentially feeling of powerlessness that I think a lot of providers feel when they see patients over and over again, or are not able to affect change in the really larger systems that affect the patients before they come to the hospital. So to me, that's an additional argument for why population health has to be at the core of what we're doing.
Can I offer something which builds on the last two comments? I think the reframe that has to happen, and this is a tall order, is that our core concern should be with the health of populations. The individual curative approach is really a subset of the core concern. Now, that's not how our system's structured, right? I mean, you are, to Tomas's point, right? You're a large clinical medical center, and attached to it you have a small population health enterprise. Ultimately, but the reframe should be the population health enterprise should be the larger enterprise, and a subset of population health is individual health, and individual health, curative health, when the person has to become sick. But I do think that there is a well of goodwill towards that idea, even among clinicians, particularly among students. So if a population health core of interest here can help shift that frame, that could be an extraordinary benefit.
Claire, I love this reframe. This saying, why don't we just say that's what we're all here for, is population health. And that should be job number one for UCSF, and that's the real breakthrough here. And why wouldn't you then want to consider this the most important thing UCSF should be doing? Claire?
Well, I would say that it was the students who really drove the interest about having population health as one of the 6 lenses through which the new Bridges curriculum has been built. So our own students are saying, we know the depth of the social problems that are facing our patients, and so, again, it's a process. It's not going to happen overnight. But I think the fact that we're producing the next generations of students who are already thinking about population health is a really positive sign. And I don't know enough about what's going on in the School of Nursing and Pharmacy and Dentistry to make any comments, and I don't know if you want to make any comments.
No, I think that, I think you're exactly right. Thank you for bringing up your points, and I think I think you brought up 2 important points, which were both the importance of diverse backgrounds amongst our student populations, but also understanding that many of the social forces that we are talking about among the populations we're caring for are played out amongst our students as well. And I think what Claire is saying, I think our student population across all of our schools have done a very good job, I think, in keeping us accountable and to sort of reflect that back on us, and I think in very positive ways. And I would just say, I have this role within the School of Medicine, but one of the things that I was deliberate about from the very beginning was to think across all schools, because I think that the interest in this area extends across all of our schools, and I think there's a strong interest in us working together so that this is really a campus-wide initiative.
I have to we did a study of clinicians, physicians, and nurse practitioners, PAs, working at both UCSF primary care practices and San Francisco Health Network, the county system, and then we replicated this with a national sample of family physicians. And those who reported that their clinic had more resources to address patients' social needs had lower burnout scores on the Maslow burnout inventory, adjusting for other factors. The sense that these are so much the kind of things that people feel overwhelmed with, that it's not just better for the patients, but it's better for the people working in those environments to feel people are able to address those broader things. So, interesting study. Stan, you all right? Let me get people who haven't already chimed in, and then we'll come back to some folks.
Hi, my name's Connie. I was focusing more on what's the role, and as I heard the conversations going, what's the role of an academic medical center, and then I thought, what's the role of a community hospital? And I think to me, the piece that you have at an academic center is that linkages with all the other schools, and to play that role more strongly, that we link what the School of Dentistry is saying with tobacco and, with cancer. What is the School of Physical Therapy saying, along with, weight, obesity? What is the School of Nursing, School of Pharmacy? So I think the role of the academic medical center, I would come back to what you're saying, is that you have those linkages embedded and you make them stronger and more visible and more cohesive working together.
Great.
Hi, my name is Anusha. So we've talked a lot about, well, I guess my question is, what are population health exposures if we want a medical center to focus on it? Because I'm a social epidemiologist, so I think population health exposures are like income and education quality. And I don't see how a medical center can intervene in those areas. And so I'm wondering, what are the exposures and how could a medical center intervene?
Well, I don't think we should anchor the science to what is within our agency to act on. Because I see Dr. Hamad here, Dr. Hamad's published great papers about earned income tax credit over time, and I don't think it doesn't fall within the scope of the medical center to do that, but I think one should defend to the death the prerogative of a population health science agenda within a medical center to study EITC. So, I've been misunderstood in some of my writing because I've written about the need for population health, to think about population health of consequence, things that matter. But that doesn't mean that we should only be doing things that we can do something about, because ultimately our conception of what can change is often hemmed in by what we've done in the past and what we think can change. So I would challenge us to say that if you're serious, if I made you, UCSF, about building population health science as a research agenda, decide on a vision, decide on areas to focus, make sure that those areas are of concern, that they truly matter to the health of populations. I'm not so concerned about who can implement, because things are implementable that we don't think are implementable today. Ultimately, what we think is acceptable today becomes unacceptable tomorrow. What we think is invisible today can become visible tomorrow. That's my push on that.
And Kirsten mentioned the anchor institution concept. One of the things is to start thinking about academic health centers is not just what could they do in care delivery to impact this, but the economic power through employment, through investment, through procurement, and things like that. So I think it's getting out of always thinking it's just about the clinical operations and thinking we actually have tremendous levers that we're not using that would actually address some of these fundamental substrates for health.
I think just along those lines, we're talking about the role of an academic medical center. We don't actually have any of the true leaders of our academic medical center here in terms of like the chief medical officer, the CEO of UCSF Health. I think those people really need to be engaged in this conversation. And how do we leverage those resources? Much to what Tomas said, it's great. We have the public health leaders from the health department and the people who are interested in research here at UCSF, but to what extent do we have the medical systems that we're all affiliated with here at the table, having the conversation with us, committing, I bet if UCSF committed 3% of their revenues to this issue, we would have a lot of resources to do quite a bit. And they could also use that influence to engage with other health systems around the Bay Area to really make an impact.
We'll take that as a recommendation, yeah.
Hi, Kevin. I'm Fiona Donald. I'm the medical director at San Francisco Health Plan, and we're a Medicaid health plan in the city. We have 1 in 6 San Francisco residents, and it's energizing to be here. There is truly a hunger on the payer side for more information around social determinants, for additional information beyond diagnoses to really affect change and health in individuals. And it really, because of the Affordable Care Act, we are we've seen a move, to Dr. Galea's point, around things that weren't possible. We are considering paying for housing. We are investing in food support programs. It's fantastic. But it's that information that you as an academic institution provide allows us to move that needle. So thank you.
Great. Stan,
You can just steal Kirsten's microphone. You don't have to wait for me to come down here.
So I'd like to make a comment on that's related to a number of the previous comments, and one of them is Claire's new word about impact. What's the second word you have there?
Carafi.
Carafi.
C-O-U-R-A-F-Y.
The other term that's out there is collective impact. Both of these things mean that you can't deal with big, complicated problems by yourself. So even though we're a big, complicated university and we have a lot of talent, we can't do it by ourselves. So I wanted to ask Sandro if he's had any experience himself or knows of such a thing where academic centers have reached out to other sectors of society, education, labor, housing, specifically to try to address problems that are bigger than the university itself can deal with, but that the university or the academic center can provide a backbone or a focus for it. This gets into the concept of health in all policies. There's some work that we're doing along those lines, Nancy Adler and Laura Gottlieb, for example. But what's been your experience about it, and what do you think about that as a new idea or an approach that we should focus more on? And this is different from thinking about what we could do clinically, internally. It's like, what can we do as an intellectual force, as an administrative force, as a driving force for collective impact? Sectors.
Yeah, the short answer is there's plenty of examples. There are plenty of examples of academic institutions, for example, that have partnered on providing high quality early childhood education. And there's examples of academic institutions that have partnered on providing better housing. So there are multiple examples. But I think, Kristen, you said something earlier on this, which I really liked, which is you have to keep in mind what motivates academic institutions. Now, that's a very polite way of saying it. I really actually, I made a mental note. I shall use that in future, if you don't mind. Because there's also plenty of examples of efforts that then shut down because they become sort of financially unworkable. So the question is, I think you need to find the sweet spot where there is congruence of vision and sufficient financial viability to make something a long-term investment. I'm using the term sufficient judiciously because I don't think an academic medical center, I'm an optimist. I think academic medical centers will make investments if they are congruent with the vision and with the mission, because ultimately we have the enormous privilege of working in not-for-profit institutions. We don't have to turn a profit, but we have to maintain ourselves to be viable. So this is, again, where I think if you had clarity about the population health goals of the institution, if you can reframe what the medical center does as population health and have clarity of vision around that, one can imagine many such investments, which ultimately they're not that expensive in the big scheme of things, but which would actually really embed what you do in the community.
Yeah, the Boston Medical Center example is investment. So
Boston. So that emerged. Yeah, so the Boston Medical Center is a good example. I mean, now you have to be careful because that's a Boston Medical Center, which is a separate financial unit at Boston University. And I'm not sure whether
it's a county. It's a public hospital.
It is a public hospital, which is its own freestanding hospital. But the history of that is so they. New CEO, I came on, we're having multiple conversations about sort of what they should do. Then she created a task force, which I had nothing to do with actually, and they eventually emerged. Her question was, what can we do to invest in the community that is the right thing for us to do, is ultimately going to bring returns to us. Now, because they're a public institution, they're a public hospital, right, and they're a safety net hospital, they actually have a clear benefit of people being healthy. And they decided that housing was the obvious thing, and they invested in housing, which is being done. Then they give money to the university, which is evaluating, et cetera. I mean, it's a nice illustration of a clinical institution partnering with an academic institution. And Boston University also had historically done that with early childhood education, where it actually adopted the entire educational system of the town of Chelsea, which is a low-income community just outside of Boston, which Boston University essentially ran the educational system as a teaching laboratory for several decades. So that's just my current institution. There are other examples. I mean, Columbia University, where I was before Boston University, did something very interesting around prisons, actually, and around prison health, which is with a partnership with New York State Prison Hospital. So there are multiple, and these are just examples I've been involved in. That's what I'm talking about. From what I've seen, they tend to falter when they become vision discongruent and when the financial model is not well thought out.
I presume the investing in housing, it's an equity investment. It's not charity. It's not a donation. I presume there was some sense that there will be some financial return on that.
That's correct.
Less than investing in your portfolio in the marketplace.
My favorite simple example of this in our papers on this, of a simple investment that yielded financial return for an academic institution, was Montefiore in New York. Montefiore in New York decided they were drowning in red ink because of asthma exacerbations in summer because of people who were living in stuffy apartments. So they invested in air conditioners, and there's a lovely paper on this showing their cost for asthma and the rate of asthma exacerbations plummeted. That's a nice. I really like the example because it's like so banal. It's really inspiring. I'm not suggesting with it that what UCSF should aspire to is just buying air conditioners, but it's a nice illustration of a small thing that can scale up.
So I think a very important function for our academic center is to take some of these rules. Why is it that we're not buying air conditioners in other parts of the country? We don't have air conditioners in Fresno. We don't have air conditioners in a number of areas. So I would say that the scalability of successful models are very important for replication, but also replication with fidelity to really assure that we don't waste 17 years before one thing that was studied in one area gets replicated elsewhere.
One of the enormous lost opportunities that I feel like all of us in health have all the time is that there are innovative programs within the health practice space, and I'm using the term generally on purpose, that is not documented, that is not written up in a rigorous way, that then doesn't lend itself to replication and scalability. And this is, we in this country are, we're all at fault on this, and it's because the systems are so separate. Like the public health practice system and the academic health system are separate, and we have relatively little intermingling compared, for example, to our colleagues in South America, where there's a lot more interdigitation. So I think there are countless such examples domestically. They're also globally. Like globally, I was recently at a WHO meeting, and I was just bowled over by many of these country offices doing really interesting, innovative work, which none of us here ever hear about because they're just not being written up in a scientific journal. So this is in the spirit of opportunities, that if you can frame what you do as population health and create real partnerships, we could learn and then scale.
Yes. Well,
Spherical
but I'm going to make some party comment, and then I do. Yeah,
everybody knows the spherical cow joke?
No.
Nobody knows?
No, please. Yeah, that's all right. You dropped the hint. You dropped the hint, but this is again. You got to realize the audience here.
Okay, very quickly. I'm really not funny at all.
Let us be the judge of that. Okay.
There's a village, and it's a village that depends a lot on its milk and its cheese and everything else. So milk is very important. And one day the cows stop producing milk. So it's a crisis, the farmers say. They go to the mayor and say, Madam Mayor, help us. She says, oh my God, it's a real problem. But the village happens to be abutting a large, distinguished university. So she says, I know what I'll do. I'll get a panel of scientists and they'll solve this. So she gets a panel of scientists and she impanels them 6 months. They spend 6 months, do all sorts of studies, and finally they say, we have solved this. And they say, okay, they call a big town hall meeting. The town is packed. Everyone wants to know the cows are not producing milk. And the chairwoman of the panel stands up and says, okay, we have solved this. First, we have to assume a spherical cow. So the point is that we are not very useful sometimes. We're not useful because cows are not spherical. So.
All right.
That's the spherical cow.
The spherical cow. All right. The jury's out on that one. The jury's out.
I told you I wasn't funny.
Okay, yeah, I know. But it's good. But hey, yeah, but you can drop that when you're in a tough moment. It reminds me of the spherical cow. Okay, that's good.
It's not my joke. I read it somewhere.
But there were some real pearls here. I just want you to know, Sandro and panel. Yeah, some spherical pearls. So I'm taking away a few things. If you just allow me to indulge with that. One is, why don't we challenge UCSF and say that is
UCSF, that is its business, both as a healthcare system and as a university, is health. It is not to care for individual, it's really how do we improve the health of the public. And my guess is that is something in this moment in time that there would be a relatively broad acceptance of. And I'd say more so than a decade ago that that's what we're in. And then if we're really in the mission of improving health, and we understand now, as Dan is alluding to, whether it's somebody researching epilepsy or other clinical conditions, that boy, this is so much more multifactorial than I think we really used to think about, and it was just we'd find that one genomic intervention or that one drug, but that the problems we have and the ones that you alluded to in your 3 conditions you addressed, Sandro, these, I think the problems of our time are so multifactorial that they are no longer amenable to that very simplistic mechanistic solution, and I think clinicians appreciate that too. I mean, that's kind of the world we're in. So I think maybe we need to not feel like, wow, how do we catch up at this elite biomedical research-oriented institution like UCSF, but maybe we are on that wave. That's one of your points, Claire. We are actually seeing that wave coming and are starting to ride the wave, which is really a necessary reformulation of what health is about, the complexity of it, the multifactorial, and how could you not then have a very rigorous programs in population science to be a complete academic health center in this moment in time, and that will require very fundamental science, strengthening one's fundamental science in population health, doing much more evaluation of interventions that work so we can disseminate best practices and not have to reinvent the wheel, and really build the science of what works in many different ways to do this, and then really push the engagement and implementation as the final stage of that translational arc, which seems very much, again, maybe that is something that comes well to us being more in a clinical milieu, which is how do we translate these things and not just publish them and do the research, but really actively play a role in translating them so that they'll achieve impact with our partners in public health departments and community organizations and things like that. So I feel inspired with a good vision here for what we're about, and that we should be, we shouldn't be apologetic. We should be bold about asserting everybody should catch up with us.
Kevin, I hope somebody was recording that, because I think that was a great summary of the afternoon and a sort of a charge for the way forward. So,
You want to find Dr. Cooper here, we would be remiss not to. I just wanted to say that I believe that that's already is it our vision or our mission statement? Remember when Gene Washington was provost, he spent a lot of time working on this, and they came up with advancing health worldwide, right? So that's already our statement. So really it's just saying,
what does that really mean?
What does that really mean? Yeah.
Let's hold UCSF accountable to it. Cool. Thank you, panel. Please, yeah. Nobody's thank you, but let's give them a applause.
So my reward was the participation of you all this afternoon, and thank you very much, panel, and Sandro, thank you so much for coming out and inspiring us. Thank you.